So he's an expert on it, and I just really appreciate everything he's done for us. So I hope you enjoy what he's going to talk about today. Warren George.
It's just like somebody to show up at a love fest with a calculator. And sorry to do that. Tend to at least give you some food for thought about funding healthcare. Next slide, please. Many of us are informed by religious underpinnings. I was raised as a Quaker, and found this, if we can get to it, prayer in a Quaker prayer handbook, and I was really struck by this. It has some of the standard things in there about tending the sick and soothing. Anyway, I was struck by the last one. Shield the joyous. Shield them from what? Or who needs shielded from the joyous? Next slide. This is kind of a view of the world. So here, many of us, and I kind of count myself in both sides, but there's some joyous optimism in the rally mentality. And then those of us who show up with the numbers, we always seem to look like grumpy people. As of 2020, there were more than 55 contemporary slides or studies or efforts related to single-payer model of universal care. Virtually all of them show a financial advantage to universal care. Some advocates have looked at this. Ooh, back one. Yeah. Looked at this and said, see, we're winning. And I look at this and say, I know what winning looks like. This feels like 0-55. So, next slide. And, why would anybody keep doing the same things over and over and over? So the Oregon Task Force, which I served on along with Sam Metz over here, in our final report, we concluded that looking back at all previous studies and efforts, the overwhelming reason that no effort to date had gotten to the action stage is lack of an adequate financial plan. One that is commonly understood, complete, fully and fairly funded, verifiable, accurately respectful of voter wants and tolerances for change, and is sustainable. Many efforts have hit several of these, but no plan has addressed all. So the first step in achieving a workable financial plan is come to a common understanding of some simple questions, like what is a single payer plan? How does a single payer plan save money? Can a single payer plan make me more witty and attractive? Here is a chart, major healthcare financial flows constructed for Oregon. For now, you'll be tested on it later, but for now, you only need to know that state residents are on the left side and healthcare providers are on the right side. Payments flow from state residents to healthcare providers. Everything in between is a government or a private middleman. Here is another version of that same flow chart, but with areas of financial inefficiency marked in red. Total inefficiency is about 25% of the total cost of healthcare. Most of the inefficiency is in provider billing offices jumping through hoops to get paid. The next most is in private insurance companies, which handle about 1/3 of all payments. So here is what a single-payer system could look like, with the inefficiency reduced from 20 or 25% down to about 9%. A lot of people think we could go lower than that, so that's 16% improvement. But you know, even if we don't talk about the money, you know, we need to talk about what else we get. The virtual elimination of billing, trying to sort through stacks of explanation of benefit statements. And because a single payer system would not pay a different amount based on who the patient is, major sources of inequity would automatically be eliminated. In a true single payer system, there's actually only way for providers who see people from the public for them to get paid. Any system that has more than one way for providers to get paid is not actually a single payer system. It's a multi-payer system of some kind, and doesn't mean it isn't worthy of some kind of consideration, but it's not a single payer system. So how does a single payer system save money? There was a time when the cost of healthcare in the United States was about the same as other countries. Now it's about double. Anyone who wants to bring down the cost similar to other countries needs to ask the question, where does all that extra money go? There are 2 peer-reviewed studies, which can give you the names of those later, which have addressed this question, and both came to more or less the same conclusion. This schematic illustrates that the rise in U.S. healthcare relative to other countries is fully explained by 3 significant and approximately equal causes: higher drug costs, higher health labor costs, and higher costs of financial billing and administration. And before I collect too many tomatoes, the higher cost for skilled positions is endemic to the United States. The same thing could be said of engineers. And the bigger problem isn't so much that we're overpaying our healthcare workers, it's that we're underpaying 40% of the population. The single payer system directly addresses the higher financial administrative costs by eliminating most of it. This alone could save about 16% of the total cost of American healthcare, but by itself, it does little to address the other costs of medical labor, drugs, and devices. So if you want to address those things, you have to put extra things into a bill. Just a single payer by itself will not do that. Can a partial single payer plan save money? The answer to that question is it's really not clear at all. The academic studies that have shown major savings have been based on a full single payer system. We don't know what would happen if a partial system, or if, and of course you have to figure out which partial. Is Medicare in or out, or are we talking about auto liability? There's many things that can be left in or out. But there are studies out there, including by the Colorado School of Public Health, that look at the problem and say, until virtually everyone is on the new plan, the costs could actually go up by 2 or 3%. And to envision what that's like, consider that if there was a hospital that billed 100 different plans, and you managed to get half of everybody on those different plans into a different system, you'd still have 100 plans that you have to maintain the expertise. So my view is to get to a point where you completely eliminate the billing department from the hospital. There is none. They get paid a different way. They don't get paid the same way they do now. Can a single payer solve everything? No, there's a whole list of things that a single payer can't solve, but it can't make more doctors, but it can make the doctors we have more efficient with their time. And if you want to be more attractive or witty, if you need some dental work or an antidepressant, it can do that. So one of the basics is that to be a good plan, it needs to be complete. And to be complete, it needs to include startup costs, reserve costs, operating plan and costs, retraining costs of displaced workers, the full economics of changes in behavior. What are people going to do when, if you've got a lot of 60-year-olds, dual income, and one only works for the benefits? How much is that going to change the workforce? There's a lot to be considered, and a lot of these things are being considered in Oregon, by the way. Another issue that studies maybe don't fully acknowledge are the sheer size and scope of what a single payer plan is. Financially, an Oregon single payer public corporation would be the largest corporation in the state, public or private. This would be true in many states, and it's a big deal and requires a lot of diligence. Big challenge for a single payer effort: convert something that begins as a social thought into a rock-solid business startup owned and controlled by the state residents themselves for their combined benefit, with the solvency of the state on the line if any significant detail is missed or miscalculated. Of course, a good plan also has to be fully and fairly. What's the word fair mean? Funded. And even if federal waivers and ERISA law can be adequately corralled, tax structure is difficult to agree on. Everybody thinks that the only fair tax is one paid by people we don't know personally. Probably wouldn't like anyway. Any tax based on income, and in Oregon, that's the logical thing. We're one of the only states without a sales tax, and doggone it, we're going to keep it that way no matter how much it hurts us. Any tax will likely rely heavily on wages and salaries, simply because that's the largest source of income in America. Using the bubbler or broad rate, low rate tax principles discussed in T.R. Reid's book called A Fine Mess. That's another plug. I'm doing what I can here. The lowest and arguably the fairest tax would be to tax all sources of income equally with little or no little carve-outs or things. That's just everybody's in the same pool. A very fundamental decision that we don't really talk about much is whether universal care is about saving cost or about transferring cost. All major healthcare reforms to date have focused on transferring costs onto younger, onto healthier people, onto those with higher incomes. Every reform so far has transferred costs from the sick to the healthy. And once we get to where we all pay the same, we can't go any further in that direction. Cost transfer to the young has been accomplished in multiple ways. Medicare transferred the higher cost of care from older people onto younger payers through payroll taxes. Later, the ACA doubled the cost of insurance to younger people by limiting age-rated premiums. But those aren't the only ways that we've transferred the cost onto the young. State of Oregon had to come up with money to match the Medicaid expansion. State support for higher education went down about dollar for dollar with the increase in Medicaid cost. Result was a 20% increase in tuition. Cost onto those with higher incomes has been accelerating. This is a schematic showing how cost has shifted onto wealthier people a little bit over time. More and more people qualify for partial or complete subsidy. Currently, about 1/3 of people in America get free or subsidized care. A plan in Oregon would have raised that to 50 people getting free care, 50%. But the problem is that the tax rate on the rest, including, by the way, most physicians, the tax would equate to 40% of their incremental take-home pay. Oregon taxpayers, and this is calculated for Oregon, in the 5th quintile are currently paying for over half of all health care, principally through their existing federal and state taxes, which fund nearly all of Medicaid and half of Medicare. Compared with the old reforms, what makes single-payer concept different is primarily designed to reduce the cost of health care, not necessarily to transfer it. We have the choice that we can transfer cost as well, but that's not necessarily part of a single-payer system. Before a plan can be fully considered, must be verified by economic actuarial analysis by the state. This can lead to interesting situations. I showed this slide at the last Denver conference here. I wanted to kind of needle Gerald Friedman because his estimates tend to be higher. And we did a state study, and there was probably 10% difference between Rand and between Gerald Friedman. And it's not as if they're looking at a different curve of probability. It depends on who they're giving the benefit of the doubt. Any study that is done by state actuarials, well, let me say that a different way. The problem is the spread. There is too much uncertainty, and the uncertainty, the state has to guard itself from that uncertainty, so its estimates are going to be lower. To be successful, financial plan will need to be accurately respectful of the wants and tolerances of voters for change. Coming from one of two states who've really gotten whipped, 2179 at the ballot box, Oregon in 2002, Colorado more recently. I think, as many people gave different reasons for why those votes went down, I think this one has a lot to do with it. What we're thinking about is a funding scheme that is on par with Social Security and Medicare. So it took 10 years before those taxes got more than a de minimis amount. It took 50 years to fully implement them. So, if you compare what it's like to, if we went and said, gee, we're going from zero to, some tax of this. I think this is one of the things that we haven't adequately addressed. sustainability may actually be harder than any of the other attributes of a good financial plan. Here's a graph depicting, for the state of Oregon, it's only 2 years old, was provided by one of our consultants, who is saying, oh, if healthcare goes up by 5% every year over the cost of everything else, there's the funding gap. Well, that doesn't work in a public funded system. You're going to have a tax, and it has to last pretty much forever, unless you're going to have another vote. You know, are we going to approve a 16% tax now, and in 5 years that's going to go to 24? So, next slide. You know, here is the history, and showing healthcare costs rising and rising as a percentage of our disposable personal incomes. And what we're really trying to achieve is this, that goes, you know, how do we do that? Well, that's going to take a lot of thought, and it's going to take some sacrifice. We may have to give up some things that we have, but that's really what we have to get to. We have to wean ourselves from the system of, oh, if we just find something we knew we'd like to spend money on, we'll just spend money. You know, it becomes a little more of a zero-sum game. If we want a new procedure, we have to get something simpler from an old one. In summation, don't be number 56 on the list. You know, I plead with everybody to work diligently on these. And the hope is that a true dedication to our civic spirit will allow all of us to lay down our differences, compete for the joy and satisfaction of cooperating for the common benefit. Here's, you can get more information at variedstrengths.com. And we've got 2 minutes for questions.